weeks ago, Chantay Jett, who's the director of the Wellness Center, and Mollie Cudmore,
It's cool. It's all good.
who's the clinical director at the clinical director at the Wellness Center, did a presentation for Rotary on suicide. And it was a terrific presentation. And the stats, which I sent out on, and they were old, there are newer stats, which you'll probably get today, make this a critical issue for the state, well, across the nation, but for the state and for Wallowa County. So I asked them to come and do the same kind of presentation, only they get a little more time to do it here at the Josephy Center. We're recording this, so people, I know somebody just came in and said they had a meeting, so people will be able to see it later. You just won't be able to ask questions, okay? If you have questions, go ahead and put them in the chat, and I'll let, are you going to start, Mollie, or is Chantay?
Yeah.
Okay, Mollie's going to start, and I'll let her start. I fiddled around for my 3 minutes or whatever, so hopefully a few more people have logged on in that time. And we really appreciate your coming here. Can I tell a story?
You may, as long as it's a good one.
Well, it's not a particularly happy one.
Okay.
My son Matt is 47 years old, and when he was 15, he was in the house with a young boy from Wallowa County who committed suicide. And that has rippled through his life and our lives for the last 32 years.
Yes.
Okay? Important stuff.
Yes.
Okay.
Thank
Thank you.
for sharing.
Thank you, Rich. Yeah, and my heart goes out to you because the impact that suicide completion has on families, on individuals, on communities is so evident and so pervasive, and it does stay with you for a long time. I started studying suicidality really in Alaska. I lived in a village. It was 5,000 people, but it was nonetheless a village in the western part of the state, and I was very saddened and intrigued by why this occurred, how do we prevent it, what are the pieces that are involved with it, and so I started to really lean in and study what causes suicidality, but also what helps prevent suicidality. So we're going to talk a little bit about that. My name is Mollie Cudmore. I'm Ida's neighbor. Sorry. So it's really enjoyable to see you here. And Chantay Jett, and we do work for the Center for Wellness. We have a vested interest because of what's gone on in our community over the last 2 years specifically, and within the last 13 months really specifically. So just to give you a little bit of context, oops, I'll have you be the little clicker.
I can do that.
That would be great.
I think. Maybe. There we go.
Great. Some context. Up until 2019, we are the CMHP, the Community Mental Health Provider for the county of Wallowa, and we provided all kinds of supports for mental wellness, including looking at therapeutic intervention with one-on-one. We would do groups, we do classes. And we studied the course and brought great services. And then COVID hit. And unfortunately, we could foresee the impact it would have. And not just COVID, but social and political unrest added onto that. And so what we started to see, and what we predicted, unfortunately, that we might see is an increase in substance use, an increase in physical abuse, sexual abuse, emotional abuse, specifically among children who were still at home because of the COVID restrictions in the school setting. We saw social isolation, and as we know as humans, we're biological creatures to be around one another. When you start to socially isolate, that has a whole ripple effect within itself. We saw an increase in domestic violence. I want to give a shout out to Safe Harbors. I think they do an excellent job, and their work also increased over the last 2 years. We've seen an increase in anxiety and depressive symptoms in people who, prior to that, had never experienced any sort of symptomology along those lines. Specifically with our agency, we saw an increase in crisis calls. It tripled within that time frame. And the complexities of crisis was increased in a very different way, in a much more complicated, in a much more convoluted way of how to mitigate that crisis situation. And so our crisis workers are having to think outside the box in much different capacities in order to keep people safe, bottom line. And unfortunately, we saw an increase in suicidal ideation as well as death by suicide. So ideation is thinking about harming yourself. And you have ideation, you have intent, you have behavior, and you have method. At times, we experience moments where we feel like, gosh, if I didn't wake up, I'd be okay with that. That's ideation. When it starts to go towards intent, method, behavior, we need to be on top of that to help one another. And that's where crisis workers really lean into that piece and provide hope and provide resources. Did you want to speak to that a little bit?
Yeah, I just, I remember early, at probably the end of March, 1st of April, at the beginning of COVID, I remember sitting around as a leadership team discussing the potential consequences of social isolation. And we know from studying human behavior that humans are not meant to isolate for very long. And so we were thinking that there were going to be steep consequences, although we couldn't understand what those consequences would be. But I think looking at the last 13 months with 8 completed suicides, that is part of the consequence that we are seeing, especially in Wallowa County. So, yeah.
Okay. Would you mind going to the next slide?
Yep.
Okay. So fast forward 2022, 2 years into it, Wallowa County has debriefed and provided care for community members, and we've had at least 15 debriefs, not solely located because of suicidal completions. We've had tragedies, we've had car accidents, we've had all kinds of situations where we've gone to, for example, our first responders and debriefed with them. We're trying to minimize the secondary impact of vicarious trauma for our first responders. So that's happened throughout the last 2 years in various capacities and ways that we can assist.
Do you want to speak a little bit to exactly what vicarious trauma is?
So, or secondary trauma too. Yeah. When you are a first responder, your initial reaction is to go in and do biologically and do physically what you need to do to keep everyone safe. Emotionally, that usually gets put on the back burner, but that doesn't mean it's not impacting you in some way. And so we have to lean into that and realize that that impact is there. Your muscles are constantly processing everything around you, and you actually get muscle memory from that, which can be, it can manifest as chronic pain, it can manifest as stomach issues, it can manifest as headaches, and if you don't process that in a proper way, it can start to really interfere with your daily life. And so understanding that the vicarious trauma, or the secondary piece of that stress on your body, is really important to be identifying it, one, acknowledging it, having compassion for it, and then having movement to help yourself heal through that.
I think we've worked more with first responders and healthcare providers in this county in the last 18 months than we've ever integrated and worked with them in this capacity before. So it's really speaking to the stress that everyone's really feeling and the depth of what's happening here in the county.
Okay. So as you all know, there's been 8 deaths by suicide within the last 13 to 14 months. We are number 3 highest county in the state. I will say that I've spoken with other rural communities, specifically in Montana, and they're seeing similar situations. It's not just solely within our county, but it does highlight that the demographics of who we are looking at have a harder time reaching out for help, have a harder time acknowledging that they're experiencing symptoms of depression. And that's where we really need our community to kind of lean into each other, to acknowledge that mental health is, it's part of who we are, and to demystify that stigma and reaching out for help. I want to say within those death by suicides, only a quarter of them were involved in mental health services throughout our county. So what does that tell you? Those that we are serving, not just us but Winding Waters and Wallowa Memorial Clinic, we are helping. It's the ones that aren't reaching out for help.
So I'm going to talk about the trend that we've identified in the. So we have a large SAMHSA grant right now that is really looking at crisis and integrating crisis services within different provider networks within the county. And the data that we pulled in about the last 18 months really speaks to what we're seeing in the completed suicides, and that is 7 of the 8 were males between the ages of 15 and 35. 6 of the 8 were not involved in any services, including primary care or dental services. 6 of the 8 had metabolic syndrome, which is a cluster of cardiac issues as well as waist circumference that really speak to stroke or heart attacks. And 6 of the 8 also had some sort of substance use that was known. So we're really seeing a trend of folks that are not engaged in almost any services and that are predominantly male.
Which way going to next?
Yep.
You said 18 to 35?
Yeah.
So as Chantay said, determinant factors, if you look at this, can you go back one?
Go back?
Yeah.
Sorry?
And looking at it from an equation standpoint, if you include those demographic factors, of which we have pretty determinate information that COVID may also play a role, that if a person experienced COVID, it could increase that
Do
possibility.
you have that stat of your 8? How many of?
No,
We don't.
we don't have that.
Unfortunately.
Yeah.
Do you have any information on those 8 with regard to living in a family, living alone, isolation
Well,
issues?
that's a great question.
That's a really great question. Go ahead. You can speak to that.
So, involving this equation for looking at it, there's impulsivity, there's lack of hope, and relational family conflicts within 2 days prior to the completion.
Interesting.
Yeah.
And that is a big predominant factor
Right.
in itself. And so, leaning into that, well, that means that there was that conflict. What was it that kept them from reaching out for help?
Ready?
Yes, please.
Do those demographics match? You said you've been looking at rural Montana. I mean, 7 of 8 being men.
Yes, and also it matches Alaska
Yeah.
stats. So I was in Bethel, Alaska.
Oh, and okay.
And so I reviewed their statistics for a year, but this was prior to COVID, and I haven't looked at the stats since then. I imagine it's higher.
And also, I've heard traditionally as many women attempt suicide as men, but men are more successful. Is that?
Men complete suicide more.
Yeah.
So we want to be careful with language in
Yes.
using successful and suicide together.
Excuse
But
me.
no, that's okay. Just
Yeah.
for
Yeah.
the educational purposes here. And so, yes, you're right. Men are complete them more so than women, but women attempt as many times as men.
Do we have any stats for Wallowa County on attempted suicides?
That's a great question.
It's something that we've been trying really, really hard to document in the electronic health records for the people that we see, but it's something that's very, very difficult.
Sure.
It's a stat that's really difficult. There's not any one place that you
Right.
can put it within the electronic health record.
With various electronic health
Right,
records.
so it makes consistency of getting that information very difficult. So we're trying to figure out a way to have some sort of a drop down or a button that will populate in terms of trying to grab that data from the back end of an electronic health record, but currently we don't have that option right now.
Does that exist anywhere?
I don't know, Ida. That's a really good. We are in Ochin, which is a really, really big electronic health record. So there are a couple of requests that we have since doing this sort of research on our own that we're trying to get them to implement in terms of like making a drop down button so that everyone has the chance in the continuity of what we're reporting. So, yeah.
Okay. So that gives you a little bit of background on what's been going on within our county, specifically the last 2 years. What I want to help you to see now are some signs of suicidal behavior, because where we're going next is really community education. It's really about each other leaning on each other, looking out, watching for one another, and helping each other to find the resources they need. So if you wouldn't mind.
Yep.
Oh, you were. You're
Oh,
good.
sorry.
Okay.
Okay.
So here's some behaviors of signs that someone may be thinking about suicide or having ideation, wanting to die, feeling guilt or shame, feeling a burden upon others, feeling empty, hopeless, trapped, extremely sad and more anxious, an unbearable emotional or physical pain. Chronic pain is also a big indication. Next, please.
Mhm.
Oh, sorry, I'm looking at mine. Okay. Making a plan or researching ways that they would pass away. Withdrawing from friends. So their normal interaction is pretty gregarious. They start to withdraw. Taking dangerous risks. Displaying extreme mood swings, or eating too much or too little, or sleeping too much or too little, or using drugs or alcohol more often. And so these are warning signs that if you know someone, and you're starting to see those things, it would be great to be interacting and leaning in to talking with them and going that next step. Specifically, we have demographics in our county of pick yourself up by your bootstraps mentality. And a lot of our agricultural and our farming and ranching communities don't necessarily want to show that they're not doing well. And I worry for them specifically.
Yeah, I think it really speaks to the culture of who we are. I mean, it's interesting. I have, some friends from Seattle still that come to visit. And one of the things that they always comment on is you have to be a doer to live here. You cannot be a consumer of products and services because there are none here. So you really have to make your own. If you want heat, you have to build a fire. If you want food, you have to cook it. You just can't necessarily go to a fast food restaurant and pick it up, right? And these are some of the things that I think we as a community are quite talented in, right? But that also means that we don't regularly reach out for help because we are so self-sufficient and we are doers and we just, figure it out. And if we don't, that becomes a source of shame. If we can't figure out what to do or how to proceed, then we live with this intense source of shame, which oftentimes leads to anxiety and depression within people. So,
Great. So, go ahead.
Yep.
Community outreach. Here are some ways that you can provide resources for individuals, for yourself as well. We have our crisis line, which is manned 24/7. There's a National Suicide Prevention Lifeline, which is also a 24/7, which is available in English and Spanish. We also have a specified veteran support hotline. It's oftentimes hard for individuals to reach out, specifically if they don't feel they understand who they are and where they've come from. And so for our veterans specifically, which we are the highest per capita of active veterans in the state of Oregon, this is a really important lifeline for them. There is also a text message that you can utilize if you see on there. And then starting July 16th, if you were to dial 988, you would have the national hotline. That's going into effect. And that's been since COVID with increased mental health finances and support. Thinking about your support network, who can I reach out to when I need help? I would ask that of you initially. And thinking about who in Wallowa County is struggling with hopelessness that I can support. So 2 really important questions to ask yourself.
Mm-hmm.
So what does suicide prevention education outreach do? How do we do that? We start with strengthening economic supports for individuals. When COVID hit, we went out and we sought out ways that we could help individuals with resources. So we actually had case managers calling people throughout the county. I can't remember how many we ended up calling. It was over.
Yeah, so we have this thing called prevention, education, and outreach that we track. And for years it's been relatively the same, right? And that's our case managers going into the community and doing some outreach, doing some education, doing some prevention work. And during COVID, those numbers almost quadrupled. So what was happening was people weren't necessarily coming in for services, but we were going out to them, and we were providing lots and lots of really brief educational or in some cases really brief, strategically focused therapy in 15-minute blocks or 30-minute blocks. And so we didn't have as many people that we saw, but our services that we were providing almost quadrupled during COVID. And it was mostly because we were trying to meet people where they were at. So we were taking people iPads, we were taking them hotspots, we were inviting them into our parking lot if they didn't have Wi-Fi at all, and we were trying to make those connections happen.
Creative engagement, as we see it.
Right.
One of the things we also were able to do was reduce access to lethal means, and how we did that, and it's not reduction per se, but we were given a grant for gun lockers from OHA, which was really valuable to help individuals. If you look at the stats, when someone is about to harm themselves, there's a 10-minute window of time of impulsivity. And if we can prolong that, if we can push that back, and if even just having a gun lock or a gun closet to slow that process down, that is something that we were vested in doing. And so they gave us, I think, quite a few, like 15 or 20 different, and they're all gone now.
Yeah, 30 altogether, like 16 really large gun cabinets, and then medium-sized ones and very, very small ones, which people also use for medication, locking up medication if they were nervous about taking too much, again, because that can be another lethal means. And so, yeah, we've given them all out. In fact, I just bought 2 more that I gave out.
So that focus, to me, indicates that that's one of the most lethal ways of a person harming themselves.
Yes, that is correct.
Yeah.
Mm-hmm.
So community-based protective factors through lessening stigma, like for example today, is really valuable in helping people to realize that mental health is just part of our overall 8 dimensions of wellness, and that we also need to really acknowledge that. And not that it's a weakness, it's actually a strength to be able to identify that. Okay. So we continue to promote connectiveness, such as meetings like this, and connectiveness with events, and having people start to go out in the community again. Start to do the things that they love to do that make their soul sing, right? We need to activate those neurons in our body again in terms of interfacing with each other in community events, and we're starting to see an increase of that, which is great. Peer support, we now have 4 peer support specialists on staff, which is an innovative, creative engagement way to get people into services or provide resources. And that's really been an improvement because they don't have to be necessarily engaged in services with us, but we can provide resources and support. Teaching coping and problem-solving skills through groups, through classes, through integrated with other agencies, and then parenting skills and family relationship programs.
I tried to follow the peer support thing, but it was a bunch of word salad. What's a peer support program?
A peer support is someone who has lived experience. So for example, let's say substance use, and they have been able to gone through the stages of change, which there's 6 stages, and been able to been successful in making sure that they're not engaging in substance use, which has probably caused quite a few problems in their life in the past. And so they're a lived experience person, so when you meet with them, you know that they know exactly what you've gone through. And so we have 4 individuals who are designated in that capacity to help provide support for mental wellness, substance use in our community. In fact, we have a Narcotics Anonymous group starting on Friday, and we haven't had one for 2.5, 3 years, and those peers will be leading it.
So what happens is, as Mollie said, for folks, there's a very, very short time of engagement. And for folks struggling with substance use disorder, it's about 7 minutes. So if someone is coming into a hospital or into primary care or a situation where they're meeting with a provider, we have about 7 minutes to engage that person. And the easiest way and the most successful way to do it is someone with their own lived experience that can speak directly to that person about where that person's at. So we've seen engagement numbers with folks that we've never seen in services who aren't court mandated, struggling with substance use disorder, increase dramatically. And in fact, so much so that the hospital's chief medical officer, Dr. Elizabeth Powers, contacted me and said, Chantay, we have a really good problem and we have a really bad problem, and it's the same problem. And I said, well, what is that? And she said, well, we've never seen this many people entering into the hospital system trying to detox. And she's like, that's a really good thing, right? We want to make people better. The bad problem is that the efficacy of effectiveness in a hospital type detox situation is very low. It's not very effective. So she's like, we have to build something different, which I just got a grant, and we are working on what's called a level 2 detox. And we're going to try to put that nestled within Wallowa River House down in Wallowa. And the reason that we're putting it there is because it will have 24/7 nursing oversight, which is really important for these people who are detoxing. And it will also be supported by the peers. And the peers who have detoxed themselves maybe once or multiple times understand where that person's at and can wrap services around them. We can care for them and we can make a plan for them. That will be much more effective than someone entering the hospital, detoxing, then leaving, and 2 months later returning to the hospital to detox again. So I think we're on to something that's going to be more successful than we've seen in the past.
Great, thank you. Next slide. Okay. Am I on the same one here?
I don't know.
I don't know.
Community action plan?
Community action plan, okay.
Okay.
Sorry, I couldn't read that. So that's where we're at next, is what is our community action plan? And I'm going to have Chantay speak to the Wallowa Network of Care, but we have a list of things that we are implementing throughout the community for the next several years in order to provide more support and provide more hope and provide more resources for community members.
So Wallowa County Network of Care is a group of providers. There's currently 17 different agencies signed up. Dr. Powers and I started this group about 10 years ago now, and we have our own mission and vision statement and some value statements. And the idea of this group a long time ago was to look at what we would call high flyers to the emergency room. Why are people admitted to the emergency room over and over again? What needs are not being met? And we started looking at the social determinants of health. So those things outside of health that make up your total health and well-being. Things like spirituality, relationships, food security, transportation, housing, right? And so we got together this list and we were trying to figure out where these people who kept showing up in the ER were missing. What things are they missing? What needs are not being met? And as a group, a very small group back then, we tried to address those needs in a variety of ways. And it was largely successful. And sometimes we would actually have the person who was entering and re-entering the ER come sit with us and talk about their needs and talk about a better plan than entering the emergency room. And some things were really easy to fix. I mean, I'm sure you've heard the regional story about this person entering the ER over and over again and understanding through a very skillful questioning of a nurse that they had no air conditioning and they were living in an apartment that was about an average of 100 degrees. And it kept exacerbating some physical health symptoms. And the team couldn't understand why these health symptoms kept reappearing. But understanding that this person was living in a really, a very not a healthy environment, that a simple air conditioning and $400 later, the person never entered the ER again. So it was these types of simple fixes that we wanted to improve people's health and well-being. So we got this group together. We hadn't met for about 4 years. And when Dr. Powers and I started talking again, we decided that, the emphasis on our focus this year of suicide awareness and prevention could easily be the focus of this group. So we reintroduced ourselves, and we have 3 times the participation now than ever before, and I think we're going to do some really good things together.
Mm-hmm. So we meet first Tuesdays, 8 a.m. at Hearts for Health.
Yep.
Everyone's interested. So zero suicide, if you want to talk a little bit about that. That's okay, we're going to go through all those pieces.
Okay.
So.
All right. So Zero Suicide is a foundation that was created for evidence-based care in reducing suicide. A number of years ago, I believe it was Wallowa County, had an epidemic of youth suicides. And it was just intolerable to the executive director of community counseling solutions. And she searched and searched for a program that they could implement countywide that would help in the reduction of suicide. When they did that, they've had no suicides completed since the implementation of this program. So I contacted her and decided that this was something that Wallowa Valley Network of Care could easily implement amongst the people who sit at that table. So we are just now starting that process.
Great, thank you. One other piece we're going to be bringing in is the Happiness Project. I'm not sure if any of you have heard of this. It's out of University of Montana, and John Summers Flanagan, who historically has a background in working with loss, working with bereavement, and started to really lean into understanding of looking at suicidality from a strengths-based perspective. And that revolves around a little bit like what Chantay was saying regarding language that we use, regarding how do we address when someone's feeling overwhelmed? How do we talk to them? Are we making sure we're not shaming? Are we making sure we're finding positive solutions? And so he's going to actually come and speak to our community, hopefully in August, and we'll learn more on how we can better implement this strengths-based perspective. Sorry, let me move to here. I can't see that.
So we have some activities planned.
All right.
Yep.
Some of the activities planned that we are implementing is QPR, which is Question, Persuade, Refer. And on another slide, I'll let you know when the next one is. This is an opportunity for community members to learn more about the signs of suicide. Learn more of how, if you were sitting with someone, what would you ask? What would you need to do next to help support them? And so this is free to our community members, and we're running it once a month for the end of until the end of the year. So that's something that you all could participate in. We're also doing mental health first aid. We also have adult and teen mental health first aid, and that's going to be implemented in the schools for the the teen and youth. Mental health first aid is open to the public as well, and it is an opportunity to learn about what is mental health, what is mental wellness, when do you start to see someone decompensate, and how are some things that you can do in motion to help that individual or yourself. Sources of Strength is a school-based support peer system. It's much like Natural Helpers, but with a different perspective, and that will be implemented this school year. And ESD we're integrating with them to work on that. CIT training is something we just implemented back in May. Do you want to speak to that?
No, go ahead. You know more about it than I do.
Well, I
just flip burgers.
Yeah, it was a opportunity of like a workshop for our first responders. So working on what is their mental wellness, working on how to integrate various pieces in their everyday profession. And so it was a week-long workshop that we put together, and there was probably close to 21 or
At
25 first responders that joined. So providing more support in that capacity.
And what's CIT?
I was afraid you were going to ask.
Crisis intervention training.
I couldn't remember the T.
Yeah.
Great. We are providing grief support groups. Those have started and have been going since January. We will be also providing a Long Haulers COVID support group in the fall. And that will be a hybrid, much like this. We have a luminary vigil that we do in September. Perhaps
On the 10th, on World Suicide Awareness and Prevention Day. And last year, our CFO, Tammy Greer, got this idea of doing a luminary vigil to honor those that are lost. And so we bought 500 white paper bags, and we advertised that, people could dedicate their bag to the person that they lost, and that if they brought their bag that evening, we would stick a candle in it and line the sidewalk outside of the courthouse. Every single bag was taken from every single location. And I get super emotional when I talk about this because it was the most amazing thing I think I've ever seen, to have 500 bags dedicated to people that have lost their lives. And it just spoke to me how much this county is grieving. And this year we are going to double the bags and do it again, and it's probably going to be a tradition. I'm really sorry.
No.
It gets me every year.
Thank you.
Yeah.
So in essence, what we're hoping to do, and what I'm hoping to ask each of you to do, is to help lessen the stigma of mental health and the stigma of asking for help. I do have a slide here. So our next event is July 6th at Hearts for Health Building for QPR, if you are interested in that. I highly recommend it. It's an opportunity to learn about yourself, to learn about our community and how to help one another, which is a vested interest I believe that we all have.
Is it a hybrid?
I
it
think
is.
it is for sure.
Okay.
And we'll post a link, and you can attend that way as well. Almost everything that we do nowadays is hybrid, so yeah.
I just took one of those classes through my institution, and the hybrid model works pretty well for those.
It
Great.
does.
Thank you.
Thank you for that.
Is it a one-off, or do you repeatedly go because it builds on?
No,
what you
it's the
learned
same
before?
information.
Yeah,
We're
it's
just
a one-off.
trying to make sure that everyone in the community has an opportunity to have it.
Yeah,
Think of it like a CPR class.
exactly. That's great.
That's
Yeah.
exactly right.
That's
Yes.
exactly what it is.
Yes. Okay. How do we view change? So if you look at change, if you look at community support from a micro, macro, meso, sorry, I'm bringing some social work terms in here. What we look at is the systematic way of providing support. So micro meaning like one-on-one. Together we can look at where each other is at and provide that support. We do that every day with, brief interventions or long-term therapeutic interventions. But that's a really great way to think about each day I have an opportunity to lean into someone who might need some support. If you look at from a macro perspective, supporting community groups, QPR is one of those. CIT was another example of that. Other groups that we are providing mental health information about, that's another form of change. And then finally, meso, well, that looks at the policy and social change. And so I'm going to let Chantay talk about that, and then we may need to, that's when we run the video. Okay.
So last year, I was invited to speak at the Senate Finance Committee for the U.S. Congressional Hearing for Mental Health. It was the second one in 100-year history that they've ever had at the Senate Finance Committee in dedication of all mental health. It was a phenomenal experience. I presented on a panel with 3 other folks and really talked about the shift of crisis as well as the policies that need to change around how mental health is funded, specifically around Medicare. If a Medicare client enters our door, the only people that can see that person that we get reimbursement for is a licensed clinical social worker, a psychiatrist, or a psychologist. In rural Oregon, Eastern Oregon specifically, licensed clinical social workers like Mollie are unicorns. They don't exist very often. So there are a number of us who are called qualified mental health professionals that can bill for everything except Medicare. So we end up losing about $500,000 a year, our agency alone, for the services that we provide to Medicare clients who we don't get reimbursed for. So part of the policy change is really talking about the funding on a federal level, a state level, and then also this shift in crisis that we are seeing. So do you want to go ahead and cue the video? Great. Or tell me how. I don't know how to do it. I'm not a Mac user.
We'll have audio going on right away. Do you want to introduce who this fellow is for folks who wouldn't know?
Sure. So this is Federal Senator Mr. Ron Wyden, and he is the chairman of the U.S. Senate Finance Committee.
I think what you and your colleagues are saying is you can't expand mental health care without expanding a trained workforce. And this is especially true in rural areas. And your eloquent words, I believe, spoke for a lot of providers from rural areas. And it seems to me you've got a big challenge filling some key slots. Licensed clinical social workers who serve Medicare and Medicaid patients, nurses who do so many things well, starting with health screens, and recovering patients who play a key role in terms of peer support. And listening to you over the years, you've convinced me these professionals are essentially the glue to holding mental health system together. Now, I'd like to get your thoughts with respect to the workforce, and particularly on the question of having enough people and then preventing burnout.
So
We're at
it's a
1
little-
minute 7 seconds. 1 hour 7 minutes.
Oh.
And 42 seconds.
Can you fast forward a little bit?
To where?
So like 108. Sorry, I had it queued up, but technical difficulties.
108.
And last year, the
Yeah.
number of emergency
It's a different
department
video.
visits for
it's
suicide
just
and drug overdoses are
It's
up
probably-
more than 25%.
Can you
3 to 4 times as many people identifying as facing
We'll
depression.
just take a moment. So like right there.
You just slide that thing down, probably.
So
Try that.
we were looking for a particular clip on here?
Yes. Yeah. Okay, and then right there. A little bit farther. A little bit farther. Because you spoke right after. There she is. Okay.
Okay.
There you go.
And it looks like you.
Yeah, that's me.
For us. For example, on the Medicare side, only licensed clinical social workers or medical doctors can treat Medicare patients for mental health services. What this means in a frontier county is if we only have 1 or 2 licensed clinical social workers on staff, then the remainder of those services being delivered to Medicare patients are being written off. In our CCBHC, we write off upwards of $500,000 a year for Medicare delivered services.
So I'm going to pause it here. There is one particular story I want Chantay to share. I was hoping we could cue it up here, but if you could just verbally tell us what you
Sure.
mentioned there.
Sure. And then we'll switch back to this.
Yes.
Switch back to the slideshow. Okay. So the story that we were trying to get to is that the clinical services that we are delivering have changed drastically since COVID. And there were years ago when I was pulling crisis shifts myself, I would have a client that would call in and was experiencing loss and anxiety. And so upon further questioning, I probed a little bit more and found out that her cat had been in a tree for 3 days. And she couldn't get the cat down, and it was causing her a lot of anxiety and a lot of loss because she didn't have the cat with her during the evenings. This was a relatively typical call, not 3-4 years ago. And the call that we took right before this Senate Finance Committee hearing was, I have a loaded shotgun, it's in my mouth, and my intent is to kill myself, click. And they hung up. We had no information. And we called law enforcement, and law enforcement suspected that they knew who it was, agreed to meet us on the scene. The clinician who went on the scene heard a gunshot, was anticipating walking into the house to not a very good scene. And fortunately, the person missed. And we were able to get that person to acute care services and prevent any further suicidal ideation or attempts. It was probably one of the scariest days that I can remember in recent history. And we've gone from a cat in the tree to a very complex situation that could have ended very poorly. and really speaks to the burnout of our clinicians right now. And workforce shortage is real. We've had 13 positions open for almost 3 years now, and we get them filled, and then people burn out, and so it's sort of like this revolving door, and it's hard. So continuity of care for folks that we see is also challenged because of rotating positions as well. And we're not the only industry, right? I mean, it's nationwide, it's worldwide. I mean, I've heard this from my family, in Spain as well. So we're not the only ones experiencing it, for sure.
Next slide.
Yep.
Thank you. So how do we make a positive impact? So what I would start with is each of you. I would ask you to identify what you're experiencing. And it could be any emotion, any feeling. And then acknowledging that. Yeah, I feel sad. I feel overwhelmed. Okay, I'm going to sit with that for a moment. And having compassion for yourself in that next step of, this is okay for me to feel overwhelmed. We've dealt with a lot over the last 2 years specifically. And then finally to have movement. What am I going to do to help myself? So a few of you in here, one in particular, has been very kind to give back to our first responders and our mental health providers in the community. And so I would encourage you to lean into those groups or other groups that you see have been really working hard the last couple of years and give them just a quick support. I would encourage you to reach out to the providers specifically who've been dealing with the COVID patients. I would encourage you to reach out to first responders. I would encourage you to reach out to each other, because we have an amazing county. Like, I moved here and I was like, and I'm never moving again. And I've lived all over the world. And it is a beautiful, special place, but part of that is our community. And so we have that added value that maybe other places may or may not. I don't want to, project, but we have the ability to help one another. And so that's where it really starts next, is how do we help one another and look out for each other? And so I would encourage all of you to think about that piece. So the next slide is probably the last. So hope. Hope makes the difference. In that moment when someone is thinking about harming themselves, they are depleted of all hope. How we can provide hope in whatever capacity, even if it's just a glimmer, will make all the difference. And so it could be a quick shout-out phone call, it could be a quick text, it could be just noticing someone not looking like themselves, like, hey, you don't seem to be yourself. What can I do to help you? Those are the questions we need to be asking one another. And that's it. Any questions?
So did anybody happen to see, it was last night? It was either on 60 Minutes the night before or the news last night. Interview with 2 people at the University of Minnesota who've written a book about violence. And they've done this huge study, and they interviewed, they identified and interviewed like 50 mass murder perpetrators, okay? And they did all these things, and it turns out that 50% of the mass murderers and 80% of the school shooters were intent on suicide. Yeah. And so their whole book, and the book is called Violence and Then Something, How We Can Reduce, but the whole thing is we have to treat mass violence and shootings exactly the way we treat suicides, because they're the same thing.
Interesting.
It was it was a man and a woman. They were very, very persuasive speakers.
Well, I have a vested interest in looking at violence because, as also living in Bethel had a school shooting back in 1995, and I was counseling people 20 to 25 years later of what that experience was like for them and the trauma that and so what I came to conclusion, one of the key factors was other people knew it was going to happen.
Right.
But no one said anything.
Yeah.
And that's where I've really honed into, we have to be there for each other.
And so is that kind of with suicide, with completed suicides, most often have there been, you said only 2 of the 8 had any connection with facilities, but were there warnings to peers, to families, with those other 6, or do we have any way of knowing?
I don't know that we necessarily have a way of knowing. I mean, looking back, we can, hindsight's always 20/20. You can pick out certain details that maybe a person should have noticed. I think the relational distress really speaks volumes. But I think in a number of situations, I would say probably at least 60 or 70% of those no one knew.
Mm-hmm. And I want to be clear that shame or that guilt, like I didn't see it, is also something we need to be aware of. It's not anyone's fault.
Right.
It's the one piece though I can think of in particular in our county regarding those 8 is that the person didn't feel like they could ask. The stigma was there. It felt like a weakness to ask.
Yeah.
And that's the piece that we really need to tease out and lean on.
We've gotten some comments on Zoom speaking to that point of demographics in the county that are way less likely to access mental health.
Yes. Yeah.
Mm-hmm. So you go to the doctor for a sore throat. You don't feel well. You have strep throat.
Yeah.
Why not go to the doctor if you're not feeling well emotionally?
Or you have a tooth that's aching. You go to the dentist to take care of it. So why don't we take care of our head or our heart that's aching too? That doesn't make a lot of sense. So we really are trying to break down the stigma and make it as as common as talking about a cold. And we hope that people start talking about it. I will say that since we've sort of turned this focus, and we have a lot that has come out in the paper, and we're trying to do an op-ed about once a quarter, as well as all the QPR mental health first aid trainings that we're doing. I will say it's the first time that I've ever seen people share their stories on Facebook. And I think I've read about 6 now, and that's tremendous. People are starting to feel more comfortable, and people are sharing, and people are posting, and I think it's just going to get better from there.
It seems to me that the younger we learn it's okay to ask for help,
Yes.
the better it goes. And I'm just figuring that in the school programs, that's
Yes.
a big component.
Yes.
And that has really improved in the last 5 to 6 years.
Yeah, it really has.
And we have a lot more, we have behavioral specialists through the schools there who are teaching all kinds of curriculum for K through 6th regarding emotional wellness and regarding their emotional intelligence. And I know that we have increased our school counseling components, as well as we have like case managers now starting to go into the school systems too. So it's much more in depth than it has been in the past, and more openness. So this, I would say, like K through probably 8th to maybe 10th grade are much more emotionally aware of themselves than previous years, and that's also a benefit.
Yeah, and they're talking about it. My daughter did a report on her own mental health and wellness around our son's accident, and she had said in the report that she was receiving services, and I was surprised by that. And she looked at me and she said, "Well, why are you surprised?" She said, "You're the champion of destigmatizing mental health." And I said, "Well, I just didn't think that you would admit to that." She's like, "I'm proud of receiving services because I'm getting better, and I want other people to get better too." And so that made me really happy that she was so comfortable in her own skin around that, and I'm hoping, like you said, the earlier we learn, the better it's going to be.
It might take a generation.
It might. It might.
I was in a first aid certification class for CPR first aid a month or 2 years back, and one of the main things that they said, okay, if someone's having a heart attack or choking, they probably don't think they need help, they're going to get up and leave.
Yes.
And in the QBR class, they said pretty much the same thing of that destigmatizing the harm, the emergency needs to happen, because if someone needs help, they might just feel nervous, get up and leave the room.
Yeah.
That speaks volumes.
Yeah. Great analogy. Well, thank you. Are there other questions?
Well, thank you very much for doing this.
Yeah.
And in a way, I'm sorry that you had to be the guinea pigs for us. doing these things.
Oh no, we're
But
good. We're good guinea pigs.
We had people had some problems getting on,
Yeah.
and I haven't quite got it figured out. But that's why I was in the other room shooting the links back to people. But,
No worries.
anyway, we do have it recorded as well.
Great.
And we'll send the link to you guys for the recording, which you can then use
Yeah.
as you
Perfect.
Perfect.
will, for other purposes. So
Thank you. Thank you for the invitation. We
Yes.
appreciate it.
no,
Really
appreciate it.
Thank you.
we in fact, we talked this morning at our staff meeting. We're going to do, Kathleen Bennett is going to do a brown bag on Medicare.
Oh, good.
What Medicare covers and what it doesn't, and what you better know about it, and
Interesting.
which we can bring in mental health things.
And it changes too. Medicare
Yeah.
changes their rules every couple of years, it seems like. I know that just my mom just having turned, or will be turning 75, there's different Medicare Part B, C, D, E, I don't know, rules that now, Kathleen has invited her in to sort of update their policy. So I know that it changes a lot. So that'll be good to have her on.
We also talked about, and we did one a couple of years ago, but it was more of kind of a pragmatic thing about housing. But I was just talking to a friend in Pendleton who said that the unhoused have become a problem in Pendleton. Now, I don't know what kind of problem we have here, but that's another thing that people were suggesting.
We have a bigger problem than you would know.
I'm sure that's true.
Mhm.
I'm sure there's a lot of couch surfing and there's
Yeah.
a lot of camping and Forest Service campgrounds
Yes.
Yeah.
that we don't know about. Yeah.
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 That is true.
So, again, thank you. And if there are other things that you think that the community needs to know about, this is just one forum, but
Sure.
we do try to make it available.
That's great.
Appreciate that.
And we're going to we actually have an exhibit that's coming up, which is going to be with Safe Harbors, I believe.
Oh,
great.
fantastic.
Great.
So,
Good.
we try to work
That's great.
together.
Thank you.
Yeah.
Okay.
Sobering news, but